coronary artery disease, right? So I think we all know obesity is a risk factor and it is part of your metabolic syndrome. Obesity is a risk factor not only for coronary artery disease but also for type 2 diabetes, which again is a risk factor for coronary artery disease. Again, hypertension risk factor. So they are all interlinked. And obesity is something which we can measure to a certain extent. The commonest measurement for obesity has been body mass index, BMI, but it is not always going to be an accurate predictor to assess or to predict or to use BMI as a risk factor for coronary artery disease difficult. Now, when we say coronary artery disease, it is basically myocardial infarction or MI. And obesity is not just linked with MI, it is also to an extent responsible for heart failures. It can cause arrhythmias and sudden cardiac deaths. So there are multiple mechanisms. So we will start off with one of these images. Yeah, right. So if you see this image, this is about heart failure. And if you look at it, there are over here you have obesity, adipocyte dysfunction, altered lipolysis, insulin resistance, and there's something written here as leptin. I mean, you may have heard of leptin. You may have heard of ghrelin. Leptin and ghrelin are all group of a special kind of chemicals known as adipokines, right? So you have adipokines, myoadipokines or adipomyokines, both are ऐसे kines हैं. They tend to, I mean, interact, regulate different pathways, and they have a long, I mean, big impact on different. I mean, it causes essentially it is linked with heart failure, inflammation. It activates the inflammatory pathways if it is not in the proper numbers. So essentially, adipokines are good. So if you have enough levels of leptin, it is supposed to be a good month. Similarly, you see you have traditional cardiovascular risk factors like dyslipidemia. So dyslipidemia, we measure total cholesterol, triglycerides, we have LDL, VLDL, HDL, right? Out of them, LDL is notorious. It is one of the major, it has association with cardiovascular risk factor, I mean, cardiovascular risk, mainly because LDL gets oxidized. It is an important pathway where you have plaque development, atherosclerosis. It promotes atherosclerosis, and so on. Likewise, HDL is the better lipoprotein, good one. If you don't have enough of HDL, it causes there is a risk factor for coronary artery disease. Again, you will see insulin resistance, increased oxygen demand, obesity leading to, I mean, fatty acid, NASH, non-alcoholic steatohepatitis, fatty liver, right? So you have increased VLDL, insulin resistance. Then you have the whole renin, angiotensin, aldosterone pathway, which impacts. You have hypoxia. Obesity can also be associated with sleep apnea, hypoxia, which again feed into the whole system. You have again insulin resistance contributing to peripheral vascular resistance, again hypoxia, and so on. So all these are associated with heart failure, not MI per se, but one of the things is heart failure. Then you also have conduction defects, arrhythmias. You see here in small, I mean, in the brackets, you have inflammation, insulin resistance. So they're all interlinked. They give you a phenotype where you have metabolic disturbances associated with inflammation, dyslipidemia, and endothelial dysfunction, a prothrombotic state, and finally, all of these are risk factors for coronary artery disease. So as we know, obesity is mostly a chronic multifactorial disease characterized by excess adiposity and alterations in the distribution. So distribution is also important. Peripheral fat deposition versus visceral fat. So you all know that visceral fat is a thing which is worse off. You may have more fat. That means you have fat in the central area in the tummy region. That is visceral fat. Whereas you have thicker, wider arms, legs, hips. Those are all peripheral fat deposits. Many times peripheral fat is better and not considered as a risk factor for cardiovascular disease. Obesity is increasing, our lifestyle is obviously to blame. Cardiovascular risk varies with adipose tissue distribution, with visceral adiposity being more strongly associated with insulin resistance, and there's a component of systemic inflammation, right, as compared to peripheral fat deposition. Obesity promotes atherosclerosis, hypertension, arrhythmias, heart failure, stroke, thromboembolism, mostly through these three, four common pathways: inflammatory, metabolic, and thrombotic mechanisms. Vascular dysfunction, cardiac remodeling, they are important components which help as predictors of cardiovascular uh, risk. Different kinds of weight loss therapies, even including bariatric procedures, have shown promise to reduce the risk, especially obesity related heart failure and fibrillations, atrial fibrillation. Visceral adipose tissue is, as we have discussed, more strongly associated with insulin resistance, inflammation, and atherosclerosis compared to peripheral fat deposition. Right? So, obesity basically is causing all these problems mainly due to abnormal or excess adiposity, which is uh, affecting the adipocytes function. It is causing a metabolic deregulation, hemodynamic instability, like prothrombotic states, then inflammation progressing to atherosclerosis, hypoxia, ischemia, all those things are there. So excess adiposity is, we all know this. We measure it daily in our labs. Increased LDL cholesterol, reduced HDL cholesterol, oxidized LDL is basically it draws a lot of inflammatory cells, mainly macrophages. You have MCP1 as a cytokine which is stimulated. Eventually, they lead to leukocyte adhesion to the arteries and vascular injury. In parallel, it also does one more thing. It reduces nitrous oxide bioavailability, impairs endothelial function, leading to vasoconstriction, plaque initiation, instability, and so on. So, obesity also creates a pro-atherogenic immune environment, enhanced monocyte macrophage activation, shift towards the pro-inflammatory T cells, and all these things are pushing the entire system towards myocardial infarction, hypoxia, ischemia, and all those things, right? Cytokines, commonly you have been reading all these wherever there's inflammation, you will know that IL-6 is there, TNF alpha is there. They're all involved with lipid peroxidation, which makes the atherosclerosis progress. So if you see, this is basically risk factors for arrhythmias. We saw in part about heart failure. This image is telling us how obesity also predisposes for different arrhythmias and sudden cardiac death, right? There is a component of atrial or ventricular remodeling, atrial remodeling because of atrial fibrillation, but the entire heart gets remodeled. Expression of receptors, pericardial fat volume, all these things are associated with these things. With regular impact of weight loss. So it is not just that obesity. So various studies have found that obesity is associated with cardiovascular risk, and there have been trials where they have studied the impact of weight loss and the risk after weight loss has happened. With this, they have observed that yes, however, you may do weight loss with diet, with exercise, or maybe with a bariatric surgery. If there is a reduction in weight from obesity, then it improves the overall metabolic environment of the person, and It reduces, I mean, it improves insulin sensitivity, reduces diabetes, reduces cardiovascular mortality, and overall risk from cardiovascular mortality. How do you measure? BMI is not a good measure. You can measure with BMI. Waist circumference is a better measure, often used clinically. And along with that, you have tests that we do in our labs. So if you talk of the core of today's talk, that is the pathophysiology, how obesity is leading to cardiovascular injury. And we understand that it is not a one simple pathway. There are multiple pathways involved. It is multifactorial. Majorly, you can consider there are 6 or 7 different pathways. The first one is associated with adipose tissue dysfunction, distribution, leading to, I mean, which eventually progresses to atherosclerosis, right? Chronic low-grade inflammation associated with that, insulin resistance, endothelial impairment because of activating various leukocytes, which then line up the blood vessels. There is reduction in nitrous oxide, deposition of oxidized pro-inflammatory oxidized LDL, which causes oxidative stress, oxidative damage. Neurohormonal activation also doesn't help. You have increased sympathetic stimulation, you have the renin, angiotensin, aldosterone pathway. All this eventually leads to various kinds of structural changes in the blood vessels and the heart. Structural cardiac remodeling happens, increases chances of thrombosis, leads the person to go towards a prothrombotic state. This image is basically summarizing what we just discussed. You can see here obesity associated with adipocyte dysfunction, adipose tissue expansion. Inflammatory markers, primarily these three, TNF alpha, IL-6, MCP1, bringing in all those inflammatory cells, leukocytes, they adhere to the blood vessels, right? Along with that, it is also stimulating Janus kinase signaling, insulin receptor sensitivity is going down, increasing insulin resistance, diabetes, hyperinsulinemia, dyslipidemia lead to free fatty acids. Again, all of them are interlinked. You see, sympathetic nervous stimulation, renin-angiotensin pathway, increased cellular hypertrophy. So there is hypertension, there is diabetes. The heart needs to pump against all these obstacles, and there is going to be cellular remodeling of the heart. Cardiac fibrosis is present, prothrombotic states, reduction in nitrous oxide, bioavailability, right? So all those pathways that we discussed, you can see them here. And then there is a syndrome like Bardet-Biedl dysfunction, where you have just a second. Yeah, yeah. Sorry. So all these things are there. So when we're talking of adipokines, adiponectin, resistin, and leptin are some of the common adipokines that are involved. In general, they are known to have a protective effect on the heart, and it is done via, I mean, it reduces the injury due to ischemia or reperfusion injuries. Most of the times in obesity, you see a fall in the adiponectin levels. It contributes to the loss of vasodilator properties. Insulin resistance develops in obese individuals as a result of these changes. Adiponectin, structurally, it's a trimeric. It may be in a trimeric form, hexameric form. There is a change in adiponectin structure in the cells, which leads to um, insulin resistance and these pathways getting activated. Elevated levels of leptin also modify the vasomotor functions of the blood vessels. There is greater endothelial nitrous en- endothelial nitrous oxide synthase expression. So it is a protective hormone or molecule. So if you, I mean, if you have, when you recollect your physiology, with regards to leptin and ghrelin, they are like opposite molecules. Leptin is more normally secreted by the ventromedial nucleus of the hypothalamus, whereas ghrelin is secreted by the ventrolateral nucleus of the hypothalamus. Ghrelin is associated with appetite, increases appetite. So, and leptin is associated with satiety. So, if you have enough levels of leptin, obviously you're not consuming more. So, when there is a calorie excess in the body, all these things happen. So, we have to be mindful of that. Along with that, resistin, which is another adipokine, plays a vital role in metabolic homeostasis. It is often found to be elevated in obese individuals. It stimulates endothelin 1 expression. Glucose and glucocorticoids induce the resistin secretion, whereas insulin and TNF tend to inhibit resistin expression. But that's like a negative feedback loop. So greater plasma resistant levels are interrelated with various inflammatory markers like the TNF receptor 2, IL-6, lipoprotein associated phospholipase, and higher CT4 coronary calcium score, which is like an indicator of occlusion in the coronary arteries. So it increases the risk. This here is a list or table of different kinds of adipokines, their role, their effects in obesity, and how it impacts the cardiovascular system. You need not remember all of them. I mean, the common ones are listed, I think, from the top. You have leptin, adiponectin, resistin, and so on. So essentially, there is an interrelation or interlinking with pathways associated with inflammation, insulin resistance, thrombosis, vascular remodeling, right? So all these things are interrelated. Now, it is one of the mechanisms by which cardiovascular risk also happens is along with obesity, increased LDL, oxidized LDL, plaque formation. So this is how atherosclerosis progresses. Causes inflammation, brings in the inflammatory cells like monocytes, macrophages, plaque is progressing, also stimulates the T cells towards the cytotoxic T cells or pro-inflammatory T cells. Along with that, reduces, I mean, by its interaction with the renin-angiotensin pathway, reducing the nitrous oxide, it is causing more of vasoconstriction, increases arterial stiffness, vascular remodeling, and so on. Now, when you talk of cardiovascular risk or MI, the things that come to our mind are various markers. Traditionally, in the olden days, you had things like SGOT or AST, which was used as a cardiac marker because of its expression in cardiac myocytes. You had LDH, myoglobin, CK, CKMB, and cardiac troponins. You can see that AST, LDH are not that specific. Myoglobin is also, it is specific but difficult to measure, but it is one of the earlier markers to rise myoglobin. CK and CKMB has been used routinely as a marker for myocardial infarction. Troponins are much more specific and sensitive. You can see from the table here, right? So these are the markers, and you will see that the first three are not specific and may be raised in other conditions also, right? CKMB and cardiac troponins, although more specific, can also be elevated in different non-MI conditions. Right? So when you talk about pathways, we realize that you have injury due to hypoxia, you have thrombolysis, inflammation, oxidative stress, neurohormonal activation related to the increased sympathetic stimulation, and fibrosis remodeling. So all these things for diagnosis, often as markers for predicting the cardiovascular risk. Right? None of them are completely sensitive or specific or can tell you the entire picture. So you see inflammatory marker, CRP on its own. So you have something known as HSCRP, which differentiates it from CRP, which is normally used in uh, sepsis or infections, right? So they have different cutoffs. You have other molecules like interleukin 6, myeloperoxidase, galactin 3, different microRNAs, and so on. So these things are there. A lot of research has happened. For myocardial injury, you have troponins and CKMB, fatty acid binding proteins, and so on. Right? If you look at the time points, you'll realize that myoglobin, along with heart fatty acid binding protein, are one of the early markers to rise. FABP is not shown in this picture. Then you have total CK, CKMB. Troponins also rise, but later than CK, CKMB. One thing you have to also make note over here is when you compare CKMB and the troponins remain elevated longer. So if there is a secondary MI or second MI which has happened, especially after a first MI, if the patient is not getting treated, there are high chances of a second MI coming in. And that time CKMB distinguishes the two episodes of infarctions, is a better discriminator than the troponins. Right. So quickly we can go through these cardiac markers. Obviously, you know them. I'll not be spending much time on each of them. Myoglobin is one of the first markers to rise. It is like the name says, it is an important component of myocytes, the cardiac myocytes, and whenever there is an injury, it's going to be elevated in the blood, right? So a negative myoglobin or low level of myoglobin can help rule out a MI, and it rises before CKMB rises. So there are certain situations where it may be a bit useful. Creatine kinase, you have read a lot about CKMB. The CKMB fraction is the most specific one. But of course, it is like we just discussed, because it gets clear it is a better indicator than troponins for detecting reinfarction. So about 15 to 40% of the CK is in the cardiac muscle is the MB fraction. That is why it is preferred. But there are also conditions where you may have overall elevation of CKMB, but there is no infarction, and that is why nowadays what we are doing is we are doing timed sampling of troponins to diagnose a myocardial infarction. You have ECG changes in ECG. Immediate cardiac troponin, maybe TROP-T or TROP-I. It gets then followed up by another measurement after say 2 hours. If you see an increasing trend, then most likely it is a myocardial infarction. If it is stable and not increasing, then it is not. So troponins, we all know that cardiac troponins are much more specific than the enzymes CKMB and CK, right? Both are used routinely. You have different kinds of assays with increasing sensitivity, and they are much more specific than the markers that are there. So ischemia alters the membrane, and then they get spilled into the plasma. I mean, after infarction happens, it is released in the plasma, right? So there are other conditions also non-specific where you may have elevation of cardiac troponins like chronic kidney disease, significant skeletal muscle injury, sepsis, non-MI conditions where cardiac troponins may increase, right? But it is still better than the other markers that we have, right? So a bit about how these troponins work. Troponin T is mainly found in the bound form in the contractile components of the myocytes. It is also found free in the cytoplasm, therefore it shows a double release pattern. Troponin I is much more specific towards the cardiac myocytes, and it is the preferred marker when you compare it with TROP-T. Troponins are released into circulation 6 to 8 hours after MI. Peak plasma concentrations are observed after between 12 to 24 hours, and they remain elevated. This year is the problem. They're elevated for 7 to 10 days, and higher levels predict adverse prognosis. It is useful for earlier detection. High sensitivity of new generation of these assays could also lead to false positive, and troponin as a cardiotoxic predictor. Like we encounter many times high levels of troponins, especially in amyloids, myeloma patients, cardiac amyloid deposition, and when cardiotoxic drugs are used. So those cases you have high levels of cardiac troponin without there being a myocardial infarction. So up to two-thirds of patients presenting with elevated cardiac troponins, I mean, may not have MI, and that is why it is important that you measure them at serial intervals and don't base your diagnosis only on one elevated cardiac troponin. Then you have things known as the natriuretic peptides, often associated with heart failure. And after MI, many times heart failure is a complication. And you have two molecules which are commonly used, BNP and NT-proBNP. BNP is the active one, yeah, is the active molecule, whereas NT-proBNP is the preform. It is inactive, but it is much more stable and better as a marker to measure, right? Because of its longer half-life. Inflammatory markers like CRP, myeloperoxidase, pentraxin 3, interleukin 6, galectin 3, lipoprotein associated phospholipase E2, these are often used as predictive markers for cardiovascular risk. CRP, although non-specific, um, it has been shown to be useful for doing risk scores and prognosticating the patients. It is a prognostic marker, not a diagnostic marker, right? So it is one of the strongest predictors of cardiovascular risk, suggesting its either usefulness in early detection and risk stratification. When you compare that with myeloperoxidase, another inflammatory marker, again, it is useful as a marker for early detection and risk stratification. Uh, so in all patients, all of these markers are not going to rise, right? So because you saw that there are six, seven different pathways which are involved with cardiovascular risk, every patient, the driving pathway would not be the same. In different patients, it's going to be different. So that is why we're depending on different kinds of markers to identify the risk, right? So if inflammation is a major component in a patient with cardiovascular coronary artery disease, then maybe these inflammatory markers are going to play a major role, right? It plays a critical role in atherosclerosis, plaque destabilization, and myocardial damage. Pentraxin 3 is a good biomarker for identifying patients with unstable angina, myocardial infarction, and heart failure. It is more sensitive to the vasculitis. So it is basically detecting endothelial damage, vasculitis better than CRP and other inflammatory. Interleukin 6 is also another indicator for early atherosclerosis, but as you know, IL-6 is used everywhere. It's for inflammation. So on its own, it's not going to tell you much, but overall, in the context of symptoms, other inflammatory markers being raised, predisposition, atherosclerosis, obesity, metabolic syndrome, hypertension, diabetes, it can have a, I mean, it helps in giving us an idea if inflammation is the driver pathway in this patient, right? Similarly, galectin 3 is another member. It correlates negatively with ventricular ejection fraction, involved with plaque formation, instability, and rupture, associated with left ventricular dilatation, and it is a good predictor for heart failures and chronic heart failure conditions. Right? There have been certain studies which demonstrated increased expression of galectin 3 was associated with increased mortality and heart failure. So those studies came out with a cutoff of 21 ng per ml, which was in, if a patient has a galectin 3 level more than 21, chances of mortality increase significantly. Similarly, this is one of the markers which are also done routinely along with lipid profiles as a cardiovascular risk. You have lipoprotein phospholipase A2. It plays an important role in formation of the plaque and also increases inflammation. Elevated LP PLA2 levels are independently associated with increased risk. Shows promise as a prognostic marker mainly for atherosclerosis, plaque destabilization, and thrombosis. Right. Then there are a whole list of novel markers for acute myocardial infarction. We have seen some of them, and there are few more which are there, like you have microRNA, circular RNAs, SERT proteins, TNF alpha, SST2, ischemia modified albumin, right? Hard fatty acid binding protein, and so on. So you have the newer markers which have shown promise. So there are a lot of studies going on and a lot of markers keep coming up. But this list are of those markers which have shown promise as either for risk stratification or as a predictive marker. So you have cardiac myosin binding protein C, hard fatty acid binding protein, ischemia modified albumin, growth differentiation factor 15, copeptin. So these are like the vasoactive peptides which are there. Then you have the opposite, the isoprostanes, adrenomedulin. When the sympathetic uh, nerves are activated, adrenomedulin gets stimulated. You have SST2 or suppression of tumorigenicity associated with fibrosis and heart failure, S100, RNA molecules, and so on. So there's a big list. You can take, I mean, if you're looking for writing an answer, you can take the main points from all of these and they will help you. So there are studies which have shown that cardiac myosin binding protein has similar discriminative power as the troponins, and it can perform better than high sensitive cardiac troponin early after the occurrence of symptoms. So like we had already seen, troponins can also show false elevations, right? So when you associate it with cardiac myosin binding protein C, it becomes a bit more specific. Then fatty acid binding proteins, there are different forms, isoforms. So heart is one of the tissues which releases fatty acid binding protein. You understand that the cardiac muscle depends on glucose and ketone bodies and fatty acids for its source of energy. So you can understand that fatty acid binding proteins are going to play a role if there is any injury to the cardiac myocytes, right? So increased FABP levels have been linked to altered myocardial substrate utilization, insulin resistance, cardiometabolic risk factors, and is considered a useful predictor and independent risk factor for cardiovascular risk. Right? And it has been associated with MI, heart failure, old age, and everything. So basically, FABP is a protein that transports fatty acids within the myocytes, and it starts rising early on in the disease onset, right? Um, Within the first 3 hours. Clinical uses, early injury detection, um, forest stratification along with BNPs and troponins, and prognostic applications. It is linked with cardiac incidents, dilated cardiac myopathy. So post MI, there are a lot of complications with certain heart failure, myopathies, and so on. So it can help in identifying or prognosticating patients who are going to land up with those complications from those which are not. Right. So here, if you see hours after symptom, HFABP is one of the first markers to rise, followed by myoglobin, and then CKMB and troponins. So this image is going to give you an idea why it is important. Ischemia modified albumin was one of the molecules which gained a lot of interest in the 1990s by Barr et al. They basically it's basically hypoxia driven changes in the albumin. So albumin binds everything, right? And the researchers found that after ischemia, albumin's binding with cobalt gets altered. It doesn't bind cobalt as well after ischemia because there are certain changes in its amino terminal that happen. Ischemia modified albumin is basically albumin which is not binding cobalt as well as it would have otherwise. And it often acts as a distinguishing marker between ischemia and infarction. Right? Then you have GDF15, growth differentiation factor. Again, it helps in risk stratification. It is associated with inflammation, oxidative stress. Uh, So when you add it with the other markers, it adds value and helps in prognosticating the patients, right? So on its own, it was associated with increased chances of recurrence of MI and future cardiovascular risk. Copeptin, it's a stable glycopeptide derived from the C-terminal fragment of vasopressin, the pro-hormone. It has been associated to be released with arginine within the first 4 hours of MI. It shows again, it has shown good correlation with myocardial infarction, and it's a key regulator of homeostasis for osmolarity and the volume of the patient after MI. It's a excellent surrogate marker, but there are certain technical challenges because it has a short half-life to measure copeptin, on a regular basis. Of course, it is not a specific cardiac marker, and it is not recommended to measure copeptin on its own. Uh, Other conditions which may give you elevated copeptins include heart failure, chronic kidney disease, sepsis, blood pressure, problem with, if reduced GFR, and so on. So on its own, it is not a very great marker for MI, but it gives us additional information for prognosticating the patients. Then you have things like isoprostanes. These compounds are derivatives of arachidonic acid. They have shown to be in high concentrations in urine of patients with unstable angina. So it works as a good predictive marker for cardiovascular risk. Similarly, adrenomedulin is a stress hormone expressed in different tissues like brain, kidney, involved in diuresis, generated from its more stable precursor, proadrenomedulin. Various studies have shown that it is elevated in myocardial infarction, particularly those developing heart failure after MI. Right? So again, it's a prognostic marker and helpful for telling us about complications post MI or chances of a patient landing up with a heart failure. There is a group of proteins known as twin proteins, include 7 groups, SERT1 to SERT7. They are stress modulators. SERT1 is the most studied one, and it has been associated with inflammation, vascular aging, endothelial dysfunction, atherosclerotic plaque, and so on. So they were decreased in peripheral blood monocytes, isolated from patients with MI, unstable angina, or other coronary syndromes. So it is basically a negative. It shows a negative correlation with the IL-6. Right. So these are novel markers where a lot of research has happened. And like we have already understood, it is not just myocardial infarction or heart failure. You have a whole phenotype where you have metabolic dysregulation, dyslipidemia, inflammation, thrombosis, where these proteins tend to play a role. This table is there to help us know the cutoffs when it starts rising, the sensitivity, specificity. If you see myosin binding protein, see good sensitivity but not so good specificity. Fatty acid binding protein has both good sensitivity and specificity, right? Ischemia modified albumin has a good predictive value for ischemia. So different kinds of cutoffs are there, depending on what mode of analysis you are using for these. Then there's another molecule known as soluble suppression of tumorigenicity 2 SST2. It is available on automated platforms like Ghosh and all. So it is useful, and it often rises along with GDF15 and hard fatty acid binding protein. Um, Structurally, it belongs to the IL-1 receptor family, and there are two isoforms that are available. So mainly we measure the soluble isoform SST2, and it correlates positively with interleukin 33 and BNP concentrations, which are again independent predictors for cardiovascular risk. Compared to other myocardial biomarkers, the concentration of the SST2 is less affected by renal function. So, especially in patients with chronic renal disease who are landing up with MI, this adds value when you compare it with the cutoffs for troponins and so on. It's a good predictor for heart failure, both acute and chronic, independent of BNP levels. So it is associated with inflammation, myocardial stress, and provides information on heart failure severity and prognosis. Talking of heart failure, obesity is also a risk factor with heart failure. You have metabolic, non-alcoholic steatohepatitis or metabolic associated steatic liver disease, which leads to muscular ectopic fat, insulin resistance, fall in adiponectins, diabetes, heart failure. You have hypoxia coming from leading to increased sympathetic activity. Uh, Leptin and resistin reduces this, but when this happens, leptin and resistin again negatively under the negative feedback loop. Leptin may fall, or if there is a leptin resistance, you may like you have diabetes resistance, insulin resistance in diabetes. You may find increased levels of leptin and resistin. Resistin again stimulates the endothelin pathway, causes inflammation, and then reactive oxygen species, all leading to heart failure. Right. Other molecules like S100, it's an intracellular calcium binding protein, which also has local regulatory effects on metabolism and cell division, associated with ischemia, myocardial injury, and again, as a risk factor, it is a good marker. Then novel markers like microRNAs, especially four microRNAs have been studied in detail, like MIR1, 133A, B208B, and MIR 499. So they are expressed mainly by the cardiac myocytes, and they are consistently seen to be elevated with MI patients. But again, they are not going to be specific because they are going to be elevated in many other conditions also. But these markers are showing promise as early diagnostic markers for MI and heart failure. Yeah. So they are as of now not being used for diagnosis, only for risk stratification of cardiovascular disease. Then you have circulating endothelial cells. These are the cells which are shed from the endothelium. Progenitor cells are mobilized due to as a response to injury. Increased levels can indicate endothelial damage. As we have seen, it is one of the 6-7 pathways which drive or which are associated with cardiovascular risk. Standardized method for measuring circulating endothelial cells was done by Manchuso, and you need a flow cytometer to measure that. So these are things where a lot of research has happened and have shown promise as good predictive markers for cardiovascular risk stratification. Right. So what we understand is any single marker is not going to help us because there are multiple pathways. Especially, we understand that obesity is not a singular disease with a singular pathway, and its impact on different organs go via different pathways, which may be common. So it is always prudent to try to take markers from any of these different pathways to identify the risk of cardiovascular disease. So myocardial damage, endothelial dysfunction, inflammation, all these things are key drivers of cardiovascular diseases, right? So multi-marker approach is what is needed nowadays, and but there are challenges. It's still a work in progress. Standardization and measuring all these things in the lab is not always easy. You have different populations, different genetic makeups, different cutoffs need to be established for all of them. Different methods may give rise to different cutoffs again. So all those things are needed, right? So we understand that there are different pathways, multiple markers, and it is basically associated with metabolic changes, inflammation, insulin resistance, thrombosis, oxidative stress, sympathetic neurohumoral pathways getting activated. All of these things are directly related to obesity, and it is not simply measuring total cholesterol, TG, HDL, LDL, although they are the easiest to measure and they tell us a lot. but there are different pathways which get activated, insulin resistance, so you can measure insulin also. So a lot of things are there. And this is how we are placed with the pathophysiology of how lipids or obesity play a key role, and what are the markers which can be measured and how it impacts overall cardiovascular health. So with this, I'll end my talk and be happy to take any questions.